but we have a couple of just minor ones to do. So the first one we're going to cover is congenital conditions that affect respiratory status of the newborn. So the objectives will be to identify congenital conditions that put the neonate in respiratory compromise, some of the presentations of the newborns, and discuss some strategies for safely transport these patients. So we'll be covering Pierre-Robin syndrome or sequence, coronal atresia, stenosis, congenital diaphragmatic hernia, which we did a bit in the previous talk. Tracheal esophageal atresia, tracheal stenosis, tracheal atresia. Not a whole lot to say on that one. We'll just, I think, Kathy, did you have one of those?
Mm-hmm.
Yeah, so Kathy can tell you all about those ones. She's the only one I know of that actually transported one of these babies. And I couldn't find a lot of information on it. It's pretty lethal, actually. Muscular dystrophy, which you may see out in the community, so I'm not going to talk about it. Usually that's a late presentation. So maybe you got CCAM, we talked about last talk, and cleft lip and palate. Okay, Pierre-Robin syndrome or sequence is a condition where the jaw is pretty much, the lower jaw is smaller, and it cuts off the airway. It's just so you can see most of you guys have probably seen this, and it's closing up the back of the airway there.
Do they surgically repair those now?
Yeah.
They do, right?
Yeah,
Okay.
it's what's it called?
They
A
distraction.
distraction.
A mandibular.
A mandibular distraction.
Right.
And they put these screws in, and then Dr. Ross still doesn't know, right? And he comes and puts it in.
So what?
He has a little screwdriver.
There's little like wires that hang.
Yeah. Oh yeah.
They look like Frankenstein.
But it's amazing. Like the kids that sit there, they take it really, but for pain. Like seriously. Anyways.
Yeah, I know.
Wow.
It's like, yeah.
I know.
I always give them fentanyl before he comes, and they only
Yeah.
do like a quarter per
Yeah, a little.
day.
Probably be like when you get orthodontic work done, maybe like
Oh,
that
sure.
ache.
Yeah, that little ache.
Yeah.
But I've seen them do it, and the kids just lie there. I mean, it's up in the nursery at least.
As opposed to walking away.
Yeah.
Exactly.
That's it, I'm out.
Yeah, I'm out of here.
I'm sure it hurts though, because the mandibular osteotomy and stuff,
Is
those
it?
kids are in serious pain, like
Really?
they're in K3 for a week.
Oh.
When we have
Okay.
them here, we always have one infusion.
Well, anyway.
Oh,
Ooh.
Don't even go there.
Don't even go there. So, you'll see probably a cleft soft palate, high arch palate, the small jaw, receding jaw. Repeated ear infections for kids who have not been diagnosed at birth. Small opening in the roof of the mouth, cleft, which will cause regurg through the nose. You may initially, on the initial newborn exam, see teeth. Yeah. And a tongue that is large compared to the jaw.
When you see natal teeth, is it usually a sign that there's something else wrong with them?
I don't recall seeing a whole lot of kids with teeth that have other issues.
Yeah.
Oh, okay.
Like,
Like it's not
It's
like
been
a
a long
warning
time.
sign to look for genetic type stuff.
no,
Okay.
not offhand.
Other teeth with a fur ball attached.
Well, yeah, that would be different.
You ate your twin.
Would you have that, please? So, you will actually diagnose this initially on the exam. And if it's maybe born outside the tertiary hospital and it's a facility that has a telehealth hookup, they may just consult you. And you may choose to bring in genetics at the same time. And a lot of cases, it's not life-threatening. Something can be dealt with later. But if the kid is having respiratory issues, well, then you need to deal with it. So considerations for transport are do not place on the back, because that will just further clog up your airway. You may want to insert an oral airway. And in some cases, in extreme cases, an endotracheal sheet may be needed to the back of the throat.
So you wouldn't place them supine, would you? Or are you just saying not flat on your back?
Not flat on the back.
Okay.
Usually, like, I've transported a couple of them, you put them prone.
I meant
Yeah.
prone, yeah.
Yeah,
Oh.
yeah.
Yeah.
Yeah, you
Yeah.
said, okay.
And you'll know right away, like you put them on their back and,
Yeah.
and then as soon as you
Just
get
not
them.
big.
Obstruct.
Yeah, yeah.
Coronal atresia and stenosis, this may be unilateral or bilateral. It's a blockage of the, from the back of the nose to the back of the throat. Unilateral may not be diagnosed initially, but may be later in life because the kid is breathing through one nostril or one area, so it's doing fine. But you may see chronic thick discharge from the open side. And so here's the blockage here. The blockage. It's the side view, so we don't know if it's lateral or bilateral, unilateral or bilateral. If it's a bilateral presentation, the baby will have difficulty breathing, of course, because they're obligate nose breathers, and especially when feeding, the kid will start choking and turning blue, and it's not yeah. Noisy breathing with cyanosis when sleeping, snoring, and of course the baby can resolve his. Sorry, that's our usual meeting. Tuesday mornings we have the usual meeting with Sandy to talk about the program, so it's canceled. And symptoms may resolve when baby's crying, if it's bilateral, because the baby's breathing through the mouth. So you may want to establish an oral airway with an endotracheal tube, and you want to insert OG tubes. You're not necessarily going to feed on transport, but decompress the stomach. And if the baby can't eat, then you may want to start IV fluids. Any questions about that? Okay, tracheal esophageal atresia. It's a connection between the esophagus and the trachea. Several types. The most common type is the blind pouch esophagus, with the esophagus coming from the stomach and attached to the trachea. And then you can have a double connection here, where there's no connection, just an H type, where an intact esophagus and intact trachea, and there's a connection between the two. Just a blind pouch with no connection. And then multiple, and then the trachea is actually gone into the esophagus, and this is fatal. So this is tracheal webs and stuff we'll talk about a little later. But it's the most common one you'll see. This is just a little study. You can see we talked about the most common one being the esophageal atresia with distal fistula. So you may see a history of maternal polyhydramnios, white frothy secretions in the mouth, a nose, choking and cyanosis during feeds, especially with key fistulas. And if it is esophageal atresia, you will not be able to pass the suction catheter or feeding tube. It's a blind pouch, so it'll come right back at you.
What's the connection with the polyhydramnios?
Why are
They can't swallow,
Okay,
right? You have babies swallow the amniotic fluid,
yeah,
right? So if you have a esophageal atresia,
so there would be that much of a difference that you've noticed then?
They might measure large for days.
Yeah.
And then they do
An
a
ultrasound.
ultrasound and there's a lot of amniotic fluid, so then that would be something that they would look for.
Yeah.
Why is the baby swallowing? And then conversely, if it's oligohydramnios, like non-amniotic fluid, why
Yeah.
aren't they peeing?
or antigen.
Okay.
So associated conditions, and the question earlier was about associated conditions, and this one actually has a lot of associated conditions, VSD, PA, right? Oh, PDA twice, sorry. Right-sided aortic arch. You'll see some renal dysplasia or agenesis, horseshoe kidneys, polycystic kidneys, imperfect anus, dual atresia, malrotations, and some musculoskeletal malformations. I just couldn't find the exact ones. But either way, just the tracheal esophageal fistula itself is a problem. You may want to look for some of these, but you're not going to get too detailed assessment in the field.
Isn't that what's her name? Olivia?
Yeah.
She was T fistula, she was cardiac,
Yeah,
so probably lateral
Yeah.
yeah.
Like
associated.
that one that you guys got right now,
RV,
Army, yeah.
Because it's a medial development in utero, anything that was medial will be affected,
Okay,
okay?
that's good way to remember it.
Yeah. So remember where it's developing? Yeah, that's actually good, yeah. Remember where it's developing and then you can figure out what's wrong. You wouldn't be able much to do about the renal problems other than fluids and perfect anus, put an OG tube in, decompress the stomach. We've come back for further investigations back there. Okay. But basically, it is a surgical issue, but for us it becomes an airway issue, and that is our primary concern. Fluids also is a problem because the baby can't eat. You want to suction the excess mucus, and you want to pass an OG NG tube if you can. Even if you need to pass in the back of the throat and just put suction on, just to keep the suction going on there. Right? It's usually a Repogel tube you put back there. We don't carry Repogel tubes. Maybe we should.
Yeah, but even if you just put the OG to the
Yeah, to the
level,
back.
you can get it too,
Yeah.
right?
Yeah, you can just drain some of the fluid out. Because it is an air, for us it's an airway issue. For surgery, it's a surgical issue, right? Congenital diaphragmatic hernia, we talked about this last time. Occurs when abdominal content moves from the chest, from the abdominal into the chest, through the diaphragm. May be present at birth, or may occur later in life. And abdominal contents basically occupy the space where the lung should be, and it is a surgical emergency. So, just the diagram of what's happening. Majority of them will be on the right side. Left side, sorry. Yeah, I'm getting this side. So the effect is usually diagnosed in utero with ultrasound. The patient will be delivered in a tertiary care facility, and there's a huge procedure on that. We deliver the moms in the children's OR. Children's OR, right? Or is it adult OR? Adult OR.
Where were the last?
Usually, no, they usually do it just on LA2.
No, oh, they've gone back to LA2?
Yeah.
Okay, so there's no longer bring
No,
back.
we only do the only ones we usually do in the OR, if they have, where the placenta is through the
Yeah.
uterus and they think there might be complications for the moms, but
That's
not
right.
usually.
Okay, there we go. Left-sided case account for 90% of the cases involving stomach, liver, spleen, and some of the intestine. Right side is less common, and bilateral is extremely common.
Rare.
Yes.
Yeah,
that
I mean, wow.
Yeah. So in case it's not diagnosed in utero, we have gone through a few unexpected ones. Maybe we'll exhibit difficulty breathing, cyanosis, tachypnea, tachycardia, decreased breath sounds on the side that's affected. Now, you keep saying bowel sounds in the chest. I've never heard bowel sounds in the chest. It's a very difficult thing to assess. But to keep putting it in as a, yes?
That one I listened to the other day, it didn't sound like bowel sounds because you're listening to the chest. It sounded like, say, crackly on that side.
Yeah.
It makes sense to be bowel sounds, but the other side was totally clear.
Yeah.
Yeah.
So you
So
could tell the difference.
are you hearing crackles or are you hearing bowel sounds, like really? And
Especially in a newborn baby though,
Yeah.
you wouldn't
You
really
can
hear
There'd be a lot of
sounds,
air.
right?
Yeah.
Yeah.
It was
Yeah.
more air moving,
Yeah. And their stomachs don't all look.
yeah, and a scaphoid stomach.
They don't always look like that.
They don't always look at that because, no, they don't actually. You're right. Confirmation is on X-ray. So complications include pulmonary hypoplasia, and it's more severe, the hypoplasia, the longer the defect. So the early defect in utero, as in diagnosed before 20 weeks, the lungs squished up and hasn't had a chance to develop. So pulmonary hypertension, gastric volvulus, malrotation of the mid-gut. And you see a lot of this actually post-surgery too. And pleural effusions right-sided, and left ventricular hypoplasia if it's right-sided. Especially when the chest is, the heart is pushed all the way over. Huge problems on the lungs. So, if you get a call like this, because we will not be present at the delivery in most cases, you want to counsel for immediate intubation, paralysis, and sedation, insertion of an OG tube to decompress whatever intestines and guts up there. If they can get a UBC in, but this is mainly for us when we get up there. Pre and post oximetry if they can. We will take I&O. inotropic support for blood pressure, and you want to keep the PO2s a little higher and CO2s a little lower for the pulmonary hypertension. Obviously, this is a case that you will be monitored very closely by medical control and Richard and us here, even while we're up there.
If you knew about that, wouldn't you bring it up? Like you really.
Oh yeah, no. This is this is not something we're going to for ourselves.
Unless unknown.
Yeah.
Yeah, unless it's unknown. I mean,
Yeah.
No, I mean, if you knew for sure what it was.
well, if you knew, yes. If they haven't actually had to prove it's a diaphragmatic hernia, well, yeah. Cleft lip and cleft lip and palate, an opening in the upper, in the lip or the upper palate. You either feel the closure of the upper lip. It's diagnosed at birth on the initial exam. It's really not life-threatening in most cases, and is correctable by surgery. So if you get a baby that's a call for this, you may want to, if you have a telehealth link up of some sort, you may elect not to bring the baby down right away. However, the feeding issues might be a problem for the referring hospital, because of course of the special feeding and nipples and OT consults. So you may bring them down just for that reason.
And lots of places don't do any garage.
Yes,
If it's
lots of
really
places don't
bad.
do large feeding. CCAMs we talked about previously, muscular dystrophy, covered on. Okay, tracheal stenosis and atresia, like I said, it's a very, it's a lethal defect. Kathy, do you have a comment on that?
You know, I'm trying to remember, I can't.
Wasn't the one that you had like several openings in the,
Yes, it
Yeah.
looked like when they did the bronch, there was no landmarking, like you couldn't see where the vocal cords were, nothing. It just looked like a big opening with a bunch of little caves. And it was like, what do you intubate?
Well, it's kind of like when Jennifer Linden Schmidt went on that transport.
Yeah.
And they had to intubate the esophagus in order, they had one in the trachea
yeah,
and one in the esophagus, and that was the only way they
that's
could
the one I
get.
was thinking of,
That
yes.
was the
That's-
only
yeah,
one they
yeah.
could get.
Yeah, mine was in the nursery.
It was in the nursery,
Yeah.
but
Yeah,
it
this
was Jennifer
one,
Linda Smith,
she
yeah.
went, and that was what they ended up, they left the tube in the trachea, but the one they were actually ventilating with was in the esophagus. They did get the kid here, but the kid died,
Yeah.
obviously.
I was
It was
on
too-
that one.
Were you on that
It
one?
was so weird because
Yeah.
it's like I know it's in the esophagus, but that's the only way I can ventilate.
Yeah.
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 So was there a fistula then, or
I don't
Well,
know
must
the
have-
results when it
must have
came
been if you were
back.
able to ventilate,
We
but,
left both tubes
Anyway.
and
Yeah.
then the
yeah.
one that I figured was esophagus is the one we intubated
Yeah.
or ventilated.
So,
Yeah.
it's a tough one, that one.
And wasn't the kid that they just put on backbone ananitis and tracheal stenosis?
Yeah, yeah, that's one they had to come and get from
Yeah.
St.
It
yeah.
was like narrowed, so
Where did my son go?
that's one where I blew up a JR bag on a tracheal stenosis kid.
What's that?
Oh,
Where I blew up a JR bag on that tracheal stenosis kid. Yeah.
Blew up?
Literally blew it
It's
up.
framed at the front. Able.
Yeah, able.
really?
You could like hear his
Anyway,
ear
somebody's
when
gone.
he's
So anyway,
in the hallway.
basically, some of these are surgical and some of them are, mostly are